Ashish Gupta, Mike Gibson. We're talking about the Guardian device, a device that you implant to detect a heart attack. Been working on this for about 20 years now. Basically, it monitors the heart. There's these screws that go into the heart muscle and monitor the EKG signal. And if it looks like you're having a heart attack, it goes off. It buzzes and an external alarm goes off, gets you to the hospital to seek care, hopefully sooner. So, Ashish, you've been using the device now for a few years. Talk to us about how it's working out there in the real world for you.
Yeah, Dr. Gibson, thank you for your time today. I think, as cardiologists and healthcare providers, the most important thing to us is to have prevention. And what we're talking about, though, is really secondary prevention because these individuals in this trial either had CABG, coronary bypass graft surgery, or had an ACS event. And so those individuals, as you know, are an increased propensity to have a repeat event. And so even despite all the best medications that we have that we prescribe to our patients, patients are still having a repeat ACS event. And post bypass, they're having events. In fact, you know better than I do that the patency rate of these vein grafts at 1 year or 18 months is not what you and I would like them to be. And so, how do we help determine which individuals are an increased propensity to have a repeat event and prevent that from happening?
Yeah, it's tough to predict, but with the alarm in, even if you're off in your prediction, it lets you know that maybe the graft has gone down or maybe there's a recurrent heart attack.
And also, I think one of the unique things about this device is when you talk about the EKG signal, it's unique to that individual. We're not talking about a device that is implanted in, let's say, you or me, and the signal is the same for all of us. It learns over the course of 2 week period your own EKG pattern, if you will, and what's normal for you. So it's normalized to the individual, and I think that's really important for all of us to understand that you have different patients that have different levels of coronary artery disease in them. And as you know as well, these plaques that are there that may have vasospasm, that may rupture, it's not the ones that have an 80, 90% blockage, it's the 20 and 30% uh, blockages that we're concerned about. And so I think for me, and I'll give you an example, I've had a number of patients now that came to see me for the first time. I sent them straight to the hospital. They needed bypass surgery. They've come back to me again. They've had an ACS event literally that day or that week, sent them back to the hospital. And they had a PCI to a vessel, maybe a vein graft, maybe to a native vessel. And if I could have detected those individuals earlier on, before they had their event or before they were about to have their event, would that be better for the patient? Secondly, I think, as you know, when your patients have an event, or all of us, when we have something happen in our lives, we realize our own mortality. And for patients, it's, I think, very comforting to know that there's a device in the high risk individuals that may detect them potentially having an event before they have it. And so a lot of my patients are very, very um, happy that there's something available to them, potentially available to them, that may be beneficial to them to help prevent events and certainly for their family members.
You made a good point, Ashish. It trains to know, when Ashish's heart rate gets up to 90, this is what his EKG looks like. And it takes into account all the changes in your EKG with different heart rates, positions, things like that. So that if your STs do change, perhaps in the absence of an increase in heart rate, it says something's off here, and that's when it alarms. And you also raise a good point about after an event, people are often very anxious, particularly those who are in the ICU setting. And there is some quality of life data from our study we did together showing that people are much less anxious with something that's going to let them know if they're going to have another event. So there is a certain quality of life uh, potential benefit here with this kind of device.
And I think that the other thing I find very interesting about the device is, sometimes patients will have an alarm, they'll vibrate, and the alarm will go off. You'll visually see it. They'll go to the hospital, and yet the EKG is normal, cardiac enzymes are negative, and so you're left in this conundrum of what do we do with this individual? They're not having an event right at that moment, but that's the very nature of coronary artery disease and vasospasm, that patients have transient changes. And unless we're capturing it at that moment, it may be very difficult to know. But we certainly know with this device that it's a harbinger for people that are going to have an event, and a precursor. And so I think those high risk individuals, I think, warrant more attention and more evaluation.
That's one of the paradoxes. If the alarm goes off, you get treated quickly, you may abort or prevent a heart attack. And so then people say, well, there wasn't a heart attack. Well, maybe by getting them there quickly, giving drugs, opening the vessel, whatever, we may have aborted any damage. So it's a little bit of a paradoxical concept that by alarming, we may be preventing the event, and then people say, well, this is a false positive. What we do know is that the number of false positives were lower when you coupled the device with symptoms. So symptoms alone gave you much more false alarms, essentially, than symptoms plus the device. So there was not runaway utilization of sending people to the cath lab, which was one of the concerns. So I think we've struck the right balance in sensitivity and specificity here.
I think the other thing is that, when patients have an anginal event, their angina is very different. They could have their classic chest pain with somebody sitting on their chest, or they could have other symptoms that are atypical. And so I think it's very unique to that individual. But what happens is, and I'm sure you've seen this, that once they have an event, now every sort of pain could be their heart. And it makes them, as you're pointing out earlier, very anxious. They're hyperacute in terms of being aware of their body. But if the alarm doesn't go off, it gives them peace of mind and saying, you know what? I didn't think that was my heart, and now I have something to back it up to say it's probably not, because it's not my index or anginal event that I've had in the past.
Any thoughts on where the technology is going?
Yeah, I think what I would like to see in the future is, the limitations that we have right now are patients that have bundle branch block, have a pacemaker. And so I think if there will be technology in the future to address those individuals, I think that would be very helpful. Um, I'm not as worried about patients that have an increased propensity to have conduction disease down the road, because certainly we can take the device out and put a pacemaker in if we need to. But I would like to see technology down the road where if somebody has a device in, we can concomitantly have this device as well, kind of like we do with ICDs, BIVs, and some of the heart failure devices that we have available to us.
Right. Well, great hearing from you. Great hearing how you're using the device and finding it useful in clinical practice. Thanks for joining us today, Ashish, and thanks to all of you for listening.